more planned. So we hope to see some of you or more of you as the year goes on. We're going to be very psych focused this year. We're in a key moment in the history of mental health nursing in Australia. In ancient times, we were taught that psychotherapy was the treatment of choice for most things. Our skills were relational. We were taught to engage with unconditional regard, to run therapy groups and offer individual, family and group therapy. In fact, my first family therapy was I was asked to join the family therapy team then at Mont Park in about 1983 or 84. We walked and talked with clients and developed therapeutic relationships. Most clients were on very few drugs. Today, however, we are in a moment of time where DSM is the framework and lens through which we are expected to understand and treat mental health. This is so despite the fact that DSM is not evidence-based, it's not valid or reliable, and the latest version, released in 2013, was created by an expert panel, over 67% of whom were directly financially linked to drug companies. There was a lot of protest about this framework, especially from psychiatrists in the UK, but here in Australia, the silence and acquiescence were deafening. Thus, our professional role, the role of mental health nurses in Australia, has become more and more medicalised and eroded. Today, driven by this framework and other pressures, medication has become the treatment of choice in mental health. Our role as nurse psychotherapists and advocates for less rather than more drugs has almost disappeared. Yet there is growing evidence that we are not in an evidence-based system. Many clients, especially in private settings, are on dozens of drugs yet seem to struggle to make progress. And if any of you have read the works of Robert Whittaker or Joanna Moncrief, you'll see that there's a lot of evidence that, for example, people with psychosis do worse in the West than they do in other countries like India that are supposedly poorer countries. We've been told a story that medication is there to treat a disease. I'm doing lots of rabbit ears, aren't I, today? Patients are regularly told they have a chemical imbalance and will have to stay on medication for the rest of their lives. However, there is increasing debate about this idea and about the efficacy of commonly used drugs, according to research cited by academic psychiatrists such as Joanna Moncrief and journalists Robert Whittaker and Johan Hari. In addition, there's a significant increase in the use of off-label prescribing. Now, off-label is where drugs are being prescribed to treat conditions that they're not initially researched or designed for because of apparently useful side effects. For example, antidepressants prescribed for insomnia. Big Pharma, undaunted and relentless in its marketing efforts, is being increasingly successful in marketing to GPs, not just psychiatrists. Ever expanding their markets via DSM, normal grief is now pathologised, and pharma now encourages giving even young children strong medication. Governments support this approach as medication offers an apparent quick fix for some difficult social issues. And all this is happening despite common factors research telling us that the therapeutic relationship, what we do as mental health nurses, is still the most powerful predictor of recovery. So as a profession, we are at a key moment in time. In my role as chair of the Psychotherapy Special Interest Group, I want to help us collectively to not just survive, but to thrive, to have more choices instead of just treatment as usual. This is a moment to reclaim our original role as psychotherapists with dignity and authority. And it's also an exciting time to be a psychotherapist. Psychotherapy has evolved significantly over the last 3 decades to include neuroscience of all kinds, like attachment neuroscience, social neuroscience, people like Porges, Siegel, Shaw, Cozzolino, and many others have added to the body of work, in addition to body-based psychotherapy such as sensory motor psychotherapy. This evolution has led psychotherapy to more focus on the experiences of childhood and on the body and the nervous system, on emotion-focused therapies, and perhaps even on more systematic approaches to working with individuals. For example, we know that people who live in poverty are going to have a higher risk of mental health conditions. There's also, I'm pleased to say, a growing interest in the quality of the therapeutic presence and engagement something all mental health nurses can aim for. And although therapeutic presence has sort of fallen a little bit out of focus for the profession, it's something that can be incredibly powerful in our work with people who are dysregulated. I presume that most of you are here tonight because you have an interest in psychotherapy. Psychotherapy offers a way forward, increased job satisfaction and pride in our profession. It's an important path out of the limitations we are in now. There are many benefits for clients too. Advocacy for clients not making progress in the current model and deep listening to clients is more urgent than ever. Later this year, I will introduce you to some beautiful people from the Hearing Voices group who have made a video and will talk to us about their experience as consumers. So the need for increased skills, supervision and practice in psychotherapy is needed by us too to reduce our, at times, over-reliance on medication. As a group, we will likely face hardships, pushback, even opposition to reclaiming our rightful and historical place as psychotherapists. We will need to closely support and encourage each other as professionals, since there is little outside support today for nurses to be psychotherapists. Mental health nurses have been pioneers among the first professions in Australia to practice psychotherapy. This year we invite you to become pioneers again and engage more actively in this almost lost but cherished part of our role. Thus, in 2021, the Psychotherapy Special Interest Group of the College will be offering regular Zoom webinars, clinical supervision in psychotherapy practice, networking opportunities, and a new introductory psychotherapy accreditation program toward the end of the year. There will be significantly more support from the college to stimulate your interest and engagement as psychotherapists. And even if you don't want to be a psychotherapist today, you'll take away some practical skills and tools that can be applied to your work now. And just a reminder, there are no quick fixes or single psychotherapy model that will solve all issues. Modern psychotherapy encourages to practice a broad range of approaches, both top-down and bottom-up. Next slide, please. Thanks. So we're starting with some neuroscience. Regarding today's webinar, we all work with people who feel too much or feel too little. Often by the time a person presents with what we call mental health issues, their nervous system has gone rogue. That's got the rabbit ears around it, functioning at either or both extremes of sympathetic nervous system hyperarousal or parasympathetic hypoarousal, or rapidly fluctuating between both states. Have you noticed that the acuity is increasing? Today's webinar aims to invite increased curiosity and appreciation for the functioning of the autonomic nervous system, which at all times is trying to function in the service of survival. Two compatible psychotherapy approaches will be discussed: the polyvagal theory developed by Stephen Porges and the structural dissociation model developed by Janina Fisher. The aim of psychotherapy with the polyvagal theory is to help the client befriend and settle their nervous system. And the aim of psychotherapy using the structural dissociation model is to help the client befriend all the inner survival-based parts. So befriending is the common theme. It's not only vital for recovery from the most extreme conditions, it also alleviates a great deal of the shame and stigmatization put onto the client through the disease model and offers vastly more hope. Obviously, it points to the therapeutic relationship too. The therapeutic relationship is a key factor in recovery. But for the purpose of this session, we'll assume that the introductions have been made and the therapeutic relationship is at least at the beginning stage with the client. In part one today, I'll discuss the limitations of treatment as usual, including the often ignored impact of childhood experience on health, how early traumatic experience disrupts nervous system regulation, and how restoring effective regulation rather than false regulation is the key to recovery. An introduction to the polyvagal theory will conclude part one. Part two will introduce the structural dissociation model and describe the work with the client, Penny, who was barely hanging on to life, alternating between extreme hyper and hypoarousal states, in extreme pain and physical collapse, highly suicidal and self-harming, furious with the treating teams, on over 30 medications, showing reactions and behaviours that seemed to make many of the health professionals around her either angry and dismissive or afraid and traumatised. Initially, she had no faith in psychotherapy and was angry that she had been referred to me. She saw therapy as something for weak people and as a last resort. However, gradually psychotherapy became a life raft for her, eventually leading to a full physical, mental and emotional recovery and a more satisfying and meaningful life. There will be time for questions at the end and in the middle, and if there is time, a little networking. Ellen will send an evaluation form along with the CPD certificate, and it would be helpful if you would take a few minutes to complete. The session today is being recorded and will be available for a review for, well, I'm not sure how long we're going to leave it there, Ellen, but I think at least a month after the webinar. References and a further reading list will be sent by Ellen if requested. And there'll be a 10-minute break at 7:15 p.m. So next slide, please. We work in a system that uses reductionist thinking to tell people they have a chemical balance that drugs will fix. This is highly debatable. Every thought that we think changes the biochemistry of our body. For example, right now, tune into your body for a moment and notice what happens when I say a couple of different words. You can leave your eyes open or close them. Now, notice what happens when I say the words yes and no. I'll say them one at a time. Yes. Check what's happening inside. And no. What happens inside? Now, what happens when I say the word borderline? And if people could just unmute for a moment and give some feedback here. What did you notice?
I heard my mum say no when you said no. My mum came to mind when you said no, Claire, so I don't know if we need to take that offline and discuss it.
I don't know.
How did everybody else feel?
I gave a wry laugh when you said borderline. I've no idea why.
Did anyone notice anything inside when I said those two different words, yes and no?
This is Sian here. I think I noticed that there was a shift from sort of feeling slightly good to feeling slightly not good, I guess, when you went from yes to no.
Yes.
And when you said borderline, I think that made me just feel a little bit, I don't know, anxious or a bit, yeah, probably felt a little nervous, I guess, maybe when you said it. So, yeah.
Yeah, interesting.
And I didn't have a reaction to the yes or no so much that I could feel. When you first said, notice what you're feeling, I thought, oh, I'm hungry. But what I did is when you said borderline, it was like, oh, the hackles raised. It's like the negative connotations of that word. So.
Yeah, it's so interesting, and thank you for these comments. And I think, it just sort of points to the fact that anything that we can experience, both an inner experience, like when we hear something that reminds us of our mother, or an outer experience that somebody uses a word like borderline, can have a profound effect on how we feel about ourselves in that moment, or about the world, or our place in the world. All of these things are interconnected. And indeed, this is what you'll find more about this as we go along, but this is what scientists and others have been studying for the last 30 years, that actually humans are very subjectively affected by all the experiences that they're having in a given moment.
Claire, can I just give some feedback? Bernadette here. I was really surprised to feel that when you said to think on yes, or to reflect on that, I surprised myself by feeling tension and with no feeling relief. But I think that has to do with that factor that you're talking about, being in the moment, because I'm actually working on saying no to client work at the moment. So yeah.
Interesting.
Yeah.
Well,
That surprised me. It was a real sense of relief that
yes,
sat in there. Yeah.
it's so, our reactions to anything are so context driven, aren't they? And I think, you know, we can't assume anything means anything. But it's very, very dependent on our state, on whether we have eaten or not before the session, or, you know, it's affected by so many things. And that's why the model that we're in, which is very simplistic, is not really adequate to explain how people get into these states of extreme arousal or collapse. And our past attachment experiences also shape the very structure and function of our brain and nervous system. And they also shape our patterns of behaviour and response and our sense of who we are. People who feel too much or feel too little have likely suffered significant adverse experiences both outside and inside the system. Their survival reflexes are simply not working properly. They're either under or over functioning. Clients have typically been told they'll be sick for the rest of their lives and that their only hope is lifelong medication. Yet, as tonight's case study will show, even in extremis, healing is possible by shifting to a trauma-informed recovery model, which includes choice and collaboration with clients and addresses the inherent powerlessness of the disease model through psychotherapy. Mental health has been shown to be not simply a condition located inside a person. It's profoundly shaped by our environment, including our relational environment. And part of that I want to really highlight is the availability of safety in relationships and the environment, and also factors such as poverty, loneliness, the amount of screen time we have, amount of exercise, contact with other people that's meaningful, quality of food, availability of meaningful activities, and our socio-economic status. These all impact mental health. We'll be talking more about the relational environment in a moment. Mental health is also very much affected by the things we do to try and manage intolerable or everyday affect. Extreme symptoms and behaviours can be thought of as survival-based attempts to cope. For example, self-harm or substance use can numb out unpleasant feelings because of the chemicals that are released when we harm ourselves or take substances. Shame and the way we judge or describe the label that has been given, like we were talking about borderline before, also has an impact. Some clients find benefit from having a label, while others feel trapped and condemned to a life sentence which has no way out. And there's a great, I don't know if any of you know of the Blue Knot Foundation, but they have some great publications on this, very well researched and evidence-based. But their latest publication offers some great perspectives from consumers on this, about how they feel about labels. And their mental health is affected by how we, as health professionals, approach mental health generally, sometimes demonstrated by the prioritization of risk over relationships in some settings, or by the prioritization of fast over slow if we're rushed for time, or by the way some people are spoken to and treated in emergency department, which we're working on now a little bit, but still got a way to go. And the way clients are either respected or disregarded by the system, by the way we tick boxes at times, rather than listening deeply to the person with symptoms. So while there is a place for treatment as usual, let's not pretend that mental health is as simple as tipping a chemical into a sour brain to sweeten it. If we dare to stop following the cult of the disease model and instead, as psychotherapists, cultivate more curiosity and kindness about the human condition, healing becomes more possible and reachable. The psychotherapists, psychiatrists, neuroscientists, and public health specialists you will be introduced to this evening have radically shaped and changed the approach to mental health and psychotherapy over the last 3 decades, and often offer a different story about mental illness with a much more hopeful and positive ending. Next slide, please, Ellen. The ACEs study began, and I apologise, I'm sure that a lot of you know all about this stuff, but I'm not assuming that anybody knows anything. So I'm going to chat back over some of this stuff, which I did present in 2019 briefly as well. The ACEs study began with Felitti, who worked for a large private health insurance company. It was Kaiser Permanente, one of the biggest in the US. And he was looking for the causes of obesity in a largely white middle-class group of Americans. He later joined with Anders from the Centre for Disease Control. Together, they tracked the health of over 17,000 people in 2 waves of data collection, asking 10 questions around abuse, neglect, and household challenges. And you can see from the slide, abuse includes emotional, physical, and sexual abuse, neglect, emotional and physical, and household challenges included things like parental separation and divorce, a parent in jail, a parent with mental illness or with substance abuse, or witnessing domestic violence. And particularly, one of the things they found in this study was that children witnessing their mother being hurt had more of a negative impact than if they were the ones being hurt, which is really, it's very sort of tender when I think about that, of what some children have to endure. The study found that adverse childhood experiences are common across all populations. 2/3 reported at least one ACE, and 1 in 5 reported 3 or more ACEs. As the number of ACEs increases, of course, the risk of negative physical, mental, or social health sequelae increases. For example, the risk of autoimmune conditions, cancer, chronic obstructive pulmonary disease, high-risk behaviours, frequent headaches, ischemic heart disease, liver disease, drug and alcohol abuse, obesity, sexual risk behaviour, teenage pregnancy, smoking, decreased life opportunities, depression, hallucinations, increased suicidality, and severity and frequency of violent experiences. All of these have been shown to have a strong and graded relationship to adverse childhood experiences, with higher scores at higher risk. People with 6 or more ACEs can die 20 years earlier than those with none. And with 4 or more ACEs, people will have 14 times the number of suicide attempts and 11 times the risk of IV drug use compared to groups with no adverse experiences. Next slide, please. So, clients with the most extreme symptoms are in fact telling a story about their past. They may not have words for their experience, and indeed it's important not to ask them too many details about their past at first. Instead, let us listen as their symptoms speak. Let us be psychotherapists. Adversity and how they adapted to survive predict future symptoms, behaviours, patterns, and life experiences. A person that I love is Judith Herman. She was and is a pioneer in trauma-based psychotherapy. I think she wrote one of the first books on linking childhood trauma or any trauma with mental health issues. And she says trauma survivors have symptoms, not memories. Often our clients with extreme symptoms may have little or no memory of their childhood, or alternatively, they hold tightly to an idealized story of a happy childhood, or we came from a close family, in order to help their emotional survival. Now, some discussion points for us. If you were a small child and your attachment figure was frightening or very unreliable, how might that shape your sense of self, safety, or trust in relationships now? And what symptoms or adaptations may arise in response to that? And we're going to have a group discussion for 5 minutes here.
Well, I think a healthy adaptation to threat during childhood is to develop high sensitivity and anxiety. Would be, in my mind, a healthy adjustment or appropriate adjustment.
And if you haven't had an attachment figure that was frightening or very unreliable, what's your sense of how that might shape your way of being in the world?
I would be very curious, cautious, reserved, insecure. You would really, well, your sense of boundaries and your sense of self would be a bit confused and not so well developed, I guess. Yeah, you would be anxious in attachment relationships.
Yeah.
I think too, Janine here, a lot of my clients often have a higher sense of responsibility. They've had to parent the parent or step into those roles of responsibility long before they should have had to. And so there's a lot of guilt. Yeah.
Absolutely.
Yeah.
Yeah.
A lot of self recrimination. Yeah. Self-blame.
Yeah.
Yeah.
And over functioning.
Yeah.
Yeah.
One of my clients has developed quite an entrenched paranoid delusional system, to use that language. And he's convinced that he's quite persecuted by police. He spent most of his adolescent years using a lot of different substances, which have probably contributed to his psychosis.
Yeah.
He finds it really, really difficult to trust. And then he kind of flips into this hopeful guy who kind of denies anything, that there's a problem and that he can go it alone and he'll be okay. There's these kind of two sides to him, and it's proves quite challenging for him to kind of navigate his life.
Yeah. Well, I think psychosis makes a lot of sense in certain settings that are really scary, doesn't it? And there's more research coming out about this now.
He was really scared as a kid, beaten badly and treated as a scapegoat by his father and his brothers.
Yeah. So symptoms are making sense, right, in the context with which they arose. Yeah.
Yeah, for sure.
Any other comments that people want to make here?
I think that having that kind of a early childhood, even with a lot of therapy, can still have profound effects. So I'm just thinking of a meeting that happened yesterday. I'm both a consumer and a nurse, a psychiatric nurse. So I have both sides of the coin. But I've had many, many years of psychotherapy and I'm pretty much, generally able to function at a very high level. However, we had a meeting yesterday at work and it was about recovery-oriented practice. And one of the things that I had said at this meeting was, look, I think we need to address this more in our framework for our service, that we have to take a more, responsible approach from the service's point of view to introduce more recovery-oriented practice. And the chair of the meeting said to me, oh, well, yes, you can do that as a champion. Why don't you start by doing it in the clinical review meetings? And I said to her, well, yes, I do. But I also have the experience of sometimes when I walk into the room, people will do a double take, draw in breath or turn around because they know that I might say something about the language that's being used. And her response to me was, oh, I don't think that really happened.
Wow. Oh, Melanie.
Yeah, so I didn't respond or anything at that point. I just said, look, well, I think it needs to be addressed from all ends. You can have the champions, but you also need the service on board. I think it needs to come from everywhere. And I left it at that.
Yeah, I think
inside, I felt, angry, but I also felt alone. I felt unsupported, all those things that it was like as a child.
Yes.
you know, without that support and so on. So
Yeah.
Gaslit much.
Well, I'm really sorry that you had that experience, and I think these sorts of experiences do go on, and we haven't got time in this session to talk about this is a very real problem too with the consumer movement. I think that the lack of empowerment of consumer representatives, if that is the role that people have, but even people like me who speak out against the system, the sort of treatment as usual system, it can be quite, what I say can be quite challenging to others as well. So I really understand what you're saying, and I think it's really important that we sort of, as psychotherapists, are taking care of ourselves and getting as much support as we can get from those around us. As I was sort of saying at the start of the session, I think we will need to sort of really work together as a group to move forward on this, because the system does need a lot of development, I think. If it's okay, we could talk about this for hours, I'm sure, but I think if it's okay, I'd like to keep moving, because I'm aware that I promised you a break at 7:15, and there's still quite a lot. So if we could move to the next slide now, that would be great. And if somebody could mute if everyone could mute their Zoom now, that would be good as well. Because I think somebody's still got their sound on. Thank you. We've been talking about the experiences of childhood and how the fear of childhood and the experiences of childhood really shape us, but they don't just shape us in a way that is social or emotional. It also shapes our physical health. And there's been a lot of research on this as well, but this slide I always like to show, because I don't know if you can see my pointer or not on your slide, you probably can't, but the small brain on the right is a child that was severely neglected in an orphanage, and the one on the left is a 3-year-old, a normal child with he only had a 50 percentile size of head now, which I think that's still quite small, but my grandson, his percentile is like 95%. It would be double the size of that. But he's had a lot of stimulation from his parents. This kid's had a normal amount of stimulation, and this child here has had extreme neglect. And you can see that actually the developing brain itself is not going so well. The image from the child at right, he had the severe sensory deprivation and neglect, and he's got enlarged ventricles and cortical atrophy. I mean, cortical atrophy is what elderly people get when they've got dementia, and this little one has got it already, and he's only 3. So it's quite profound what neglect does. So I'm just wanting to make the point over and over again that this relational thing that we do as psychotherapists is incredibly important. And also that positive relational experiences help us, help our immune system, help our physical health as well. The other thing is that early trauma can remain in the body as procedural or implicit body memory, or as a chronic pain response. There are people like Van der Kolk and Robert Scar that have written about this extensively. And Robert Scar, for example, who's an expert on, I think he's a neuro, what do doctors who do neurology, what are they called? Anyway, he's that. And he's an expert in whiplash injury. And he's discovered that most of the people who have chronic whiplash pain that doesn't resolve quickly have had childhood trauma. So it's interesting in how many ways that these early experiences can shape us. And so hopefully it's becoming clearer by now that the idea we can heal mental health disease simply by adding chemicals to the body is woefully inadequate. So luckily we have Stephen Porges, who's a neuroscientist, and he developed the polyvagal theory in the 90s. The application of his theory to psychotherapy has changed and revolutionised the way we approach work with complex clients. Next slide, please. Van der Kolk demonstrated via functional MRIs that the amygdala under constant perceived threat becomes enlarged, which means that the threat response is more easily triggered. Now, perceived threat is not the same as actual threat, but to our nervous system, perceived threat is just as scary as an actual threat. It makes sense that if we live in a dangerous environment, our threat system becomes a personal surveillance system, asking, is this safe? Because this increases our chance of survival. But after prolonged exposure to threat, the system can become sensitized. I think that's what one of our participants was saying earlier. People become sort of hypersensitized, and so then it only requires a slight or even perceived threat to activate the threat response via the HPA axis. After intense, overwhelming or frightening experiences or prolonged exposure to uncertainty, humans do become hypervigilant. And that means how we approach our clients is really important. A stare, a slight frown, a hardening of the voice, or even an internal judgment can trigger an avalanche of intense emotions or a freeze or dissociated response in some of our clients. And also the hippocampus isn't working properly. So what this means is that there are biological reasons why the sense of threat is more easily kindled, it takes longer to extinguish, and why even small events have a big impact. Clients experience the here and now with the same level of fear intensity as when they were there and then, powerless and frightened children. Now, when we're activated by fear, we go into that sympathetic hyperarousal, which is that threat response is exhausting for health and it damages the body. To balance this out, eventually our ancient survival-based part of the nervous system, the dorsal branch of the vagus nerve, will kick in, and this can result in extreme states of numbing, low energy and mood, or dissociation. People living with extremes of these states often have little ability to manage how they fluctuate between one state and another, and they may alternate rapidly between hyper and hypoarousal states, including dissociation, or they may be seemingly stuck in one, either hyper or hypoarousal most of the time. But it's interesting to note that high stress also shuts down Broca's area in the brain, so that we lose the power to describe the terror or the horror if we ever had that power. What all of this means is that talking therapy alone may not be adequate, as some of these intense experiences are pre-verbal or non-verbal. And this is where somatic psychotherapy has become increasingly important in psychotherapy over the last couple of decades. Now, I'm going to just skip the next slide, Ellen, which is the one on memory, because we haven't got time to go into all of that. But let me just say briefly that memory is also affected by trauma. It becomes quite fragmented and ropey, and often gets tangled up with embodied implicit memory from the body, which is flashbacks and intrusive sensations related to the trauma. So here we come to the central message of the polyvagal theory, which Porges developed, which is that a felt sense of calm or safety is needed for recovery. Can we go to the next slide, please, Ellen? And that the social engagement system will pull us out of dysregulated states and toward recovery. Yet the therapeutic relationship may not be the answer, at least initially, because as many of you will know, it's not always possible to create a felt sense of safety in your workplace today. Next slide, please. Stephen is the neuroscience who was fascinated by the nervous system of animals. The autonomic nervous system is made up of one sympathetic and two parasympathetic nerves, which respond to inner and outer signals and sensations, the process that he calls neuroception. The three pathways of the autonomic nervous system start with the ventral branch of the vagus nerve, which allows us to connect, play, or immobilize safely for breastfeeding or cuddling to co-regulate. The second pathway is the sympathetic nervous system, which mobilizes us to action, fight or flight. And the third and most primitive pathway is the dorsal branch of the vagus nerve, which immobilizes and conserves energy for survival, thus drawing us away from co-regulation by numbing or collapse. It's a lonely place to be. Stephen proposes that every response from the nervous system is an action in the service of survival, and that the ultimate goal of therapy is to engage the resources of the ventral vagus, the window of tolerance or the optimal zone, to recruit the circuits that support the pro-social behaviours of the social engagement system. Now, I'm a fan of Deb Dana. She's a colleague of Porges. I don't know if any of you have heard of her, but she's written some very readable and easy to understand books on this polyvagal theory and describes it in really easy layman's terms. She describes sympathetic activation after we feel uneasy. She says this is an action mode where the heart rate speeds up, our muscles tense, we find it harder to sit still. Our thinking becomes more black and white, anxious or angry as we scan for danger. Hearing becomes more acute as we listen for low frequency sounds and vibrations that might signal threat. The greater the perceived threat, the more the world starts to feel chaotic, unfriendly, unmanageable, or dangerous. We can experience this activation as anxiety, panic attacks, anger, irritability, inability to focus or follow through, hypervigilance, obsessive or compulsive behaviours, conflict or distress in relationships, or just harsh critical thinking. Severe activation increases the likelihood of misperception, difficulty hearing others, auditory or visual hallucinations, and distorted thinking. And related health problems can include heart disease, hypertension, high cholesterol, sleep problems, weight gain, memory impairment, headache, chronic neck, shoulder and back tension, gut problems, and increased vulnerability to illness. Now, the interesting thing about this sympathetic activation is that in the Western world, many of us think that this is a great way to live. We think it's good to be busy and on all the time, and it's really not. Prolonged sympathetic activation will usually lead to dorsal vagal collapse as the nervous system tries to rebalance itself. That's why anxiety and depression often coexist. The dorsal vagal complex is the path of last resort. When all else fails, when we feel trapped or action taking is not possible, the primitive vagus takes us into shutdown and collapse. Here at the bottom of the autonomic hierarchy, I am alone with my despair and escape into not knowing, not feeling, almost a sense of not being. I might describe myself as foggy, hopeless, abandoned, too tired to think or act, and the world is empty, dead and dark. I can suffer prolonged dissociation. Shame and self-loathing may be present, and there may be memory issues, depression, and chronic fatigue, fibromyalgia, low blood pressure, type 2 diabetes, gut problems, or weight gain. So that's from Deb Dana. Next slide, please. We're almost at the break. So to summarise, with clients showing extreme symptoms, the development of the therapeutic relationship and psychotherapy must be approached very slowly and with great care. Declarative memory is unreliable, and talking about the past may trigger flashbacks. The parts of the brain and nervous system that tell them that the danger is over are not working properly. Clients are likely to have symptoms rather than memories. So we're going to pause here, and I do have a list of ideas of what we should do as nurses. For example, aiming for resourcing rather than relationship. And that seems counter to everything I've been saying about the therapeutic relationship. But for people that are at these extremes of dysregulation, it's too much for them to be in relationship too quickly, and they don't trust. They have a lot of difficulties with trust. And so it's better to initially aim for resourcing rather than relationship, and to do those other things that I've listed there, and to assess their tolerance for safety or calm, because a lot of people who have these extremes have a difficulty of actually, it doesn't feel safe to feel calm or settled. They have to learn how to feel safe and settled, because it doesn't necessarily follow that their life has allowed this much prior to coming into the setting that you are working with them in. I think it's time to have a break. But I wanted to know if any of you have questions in this time. I hope I haven't bombarded you with too much of this, but if you've got any questions, I can take them about the polyvagal theory. I can take those now. Otherwise, if we can be back in 10 minutes, so 7:30, that would be great. Do we have any questions?
No, it's pretty straightforward.
Right. Okay, any other questions?
Well, thanks, Claire. All good, thank you.
Good. All right, well, if there's no other questions, I'll see you all at 7:30. Yeah, and I see that some of you are talking about Deb Dana's polyvagal flip chart, which is great, and Janina Fisher's flip chart is great as well. So yes, there's some good resources there.
So, Claire, I have a question because I'm a curious little kitten, and I, not being a mental health nurse, but an honorary one, thanks to the Victorian branch awarding me that honour a little while back. I wonder, and I'm sorry if this is a silly question, but I wonder how much of this nurses are learning in their university studies. Like, is this something that's included into the course material? Like, this isn't not in a postgrad, or?
I think the polyvagal theory may be, but I'm not sure whether it's taught in a very, I'm not sure if it's like, for example, Deb Dana's done some books specifically. I'm holding up a book of hers.
I can see it, yeah.
About the polyvagal theory and therapy, and she's got really specific ideas about how to work with clients with different presentations like this. But sometimes people get taught a bit of it, but they don't get taught the detail that she goes into about how to actually, you know, drill down and really apply it properly to the clients that we work with. So I think, you know, if people are interested, there's some really good stuff. And her website, which I think is called The Rhythm of Regulation, her website, she's got some great free, like, for those of you that like worksheets with your clients, I don't know if people like those, but she's got some great free worksheets you can download as well, and some videos and things like that. So yeah, and her flip chart's great too. So yeah, there's some good tools out there, and also the Blue Knot Foundation have some good sheets, handout sheets for clients that just explain a bit about trauma generally, and working with trauma and how trauma can be healed, things like that. So there's a lot of good resources out there now people can access. Yeah, but no, I think more of it probably should be taught, but I think that's still an evolving area. Some places do it better than others.
Yeah. Yeah, and I think the course content, from my understanding, changes vastly from university to university, but that seems to be something common. But yeah, I wondered. I thought this is.
No, you're absolutely right. Depending on which undergrad university, which university you do your undergrad nursing will depend on whether you have any mental health units that are core units. Beacon University have 2 undergrad mental health units as core units, but that's because Patricia Sands, was a chair of that department for a long time. So, yeah, there are universities that don't cover any sort of area of mental health at all. Postgrad, again, I think that probably depends on which university you attend, which postgrad you do in mental health nursing. And I suppose it's tricky as well. I think sometimes education, maybe it's geared towards, I don't want to say fashion, but government funding is geared to short-term psychotherapy, well, not psychotherapy, or I don't know, psychotherapy, cognitive behavioral therapy. That seems to be the, that's the choice, because you can get it all done in 10 sessions. In the real world, we know, no, you can't. There are some things, yes, you may be able to get done in 10 sessions, but there are many things you can't. So, I think sometimes it's driven by government agenda as opposed to what people actually need for recovery, in my opinion.
Yeah, absolutely. And I looked when I took over the role of chair, I did look at a lot of the postgrad course offerings around Australia, and I noticed that many of them lacked quite a lot of the thematic, that it was very cognitive what they were being taught. And these days we're supposed to work top down, which is the cognitive stuff, as well as bottom up. And even things like EMDR, you could call it either top down or bottom up theoretically, because the brain affects both sides of the body. But there's not much of that, not much of the embodied stuff, and that's where I think Deb Dana's work's quite good, because she talks about the body quite a lot in her books.
And Peter said UTAS has psychotherapy in the mental health nursing stream. All right.
Right. I wonder what sort of psychotherapy, because CBT is what we learned. It used to be called, it was called something else. Anyway, yeah, it's been around for a long time, the cognitive behavioural stuff.
Still emotive therapy, Claire?
Yeah, I think so.
Yeah. That's what we learned it as is in my undergrad training. One of the things I was going to say before, when you were talking about the adjustments we make when we're little to deal with the developmental challenges and so forth, one of the things that I really liked when I did my Gestalt psychotherapy training was the idea that these are creative adjustments we make to survive, and sometimes they get habituated and then become past their use-by date as we get older. And whilst I don't mind the terminology defence mechanisms, and I love the concept, there was some indoctrination in my training that defences were not good. We weren't encouraged to think about them, that they actually help us survive. When I did my psychotherapy training, I really loved the idea that they were creative adjustments that we made to survive our childhood issues, whatever they be. And I found that really very, very helpful in just for a reframe for me. And the other thing that I do remember when I did the psychotherapy training is my supervisor at the time would encourage me to think of myself as a psychotherapist, as a mental health nurse, which I balked at, and I just did not feel comfortable with that. And whereas once I'd actually completed my training, or at least partway through, I felt like I could hold myself when I was talking to other brands of psychotherapists, if you like, and understand the different terminology of what one might call one thing and how they might look at differently at another thing or emphasize a certain point or point of difference. And, you know, we learned a lot of bits of things, but we never really learned psychotherapy properly. But we did learn therapeutic relationship properly, which I think is so sad, and we've lost it. So that's just my ponderings as I've been listening to you, for what they're worth.
I appreciate that, and I do think there's room for us to re-engage with that idea of therapeutic presence. When I was studying a couple of years ago, I tried to do like a mini thesis on therapeutic presence, and it's actually quite complex because we are so affected by everything that happens around us, even if we think we're not. So, you know, I think it's something, and maybe it's something that I think later in the year I've asked Finbar Hopkins is one of our members, and she's going to give a presentation on therapeutic presence, which I'm hoping that people will get a lot out of, because I think it's so important. So yeah, lovely thoughts, Julie. And the Gestalt, they have lovely ways of being with people, don't they? The Gestalt people. Nice training to do.
The problem is that we live in the CBT era, and the clients, but also referrers and the whole society wants us to focus on problem solving and change of thinking. I'm a Gestalt psychotherapist as well, and to practice in that model in the current world is not very easy because of that.
It's not easy, but there are workarounds.
Oh, of course. Yeah.
I'd challenge you on that, Peter. So I worked as a CL nurse for many years, and I suspect Claire and I have some commonality coming up in the second half of the presentation. And I worked in an extremely medical model area, very, very dominant paradigm. And I remember when I learned about the body and inquiring about the body. No, I shouldn't say I learned about the body, but inquiring about the body. And it was a young woman who had renal failure, and every time people raised the issue of having a transplant, she just rejected she just couldn't have a conversation about it, and the staff just didn't understand what was going on, because to them it was the best solution. And I'd learned a little bit about how to inquire about what was happening, and I could see it was overwhelming for her. And I simply asked the question, when people raise the idea of transplant, where in the body do you feel it? What happens to your body? And she said, I get cold in my belly, empty and frightened. And that helped me understand that the whole idea was beyond her. And so that was in a medical model environment, and it actually was a turning point for our work together. So I think you can, improvise.
I was not talking so much about your one-on-one client work, but more the environment. I work in GP clinics.
Yeah, okay. They go, Gestalt, what?
So you got well, I have to hold my ground, and I mean, it's okay, but you really gotta hold your ground.
Yeah. And I think this is what I was getting at earlier when I said I think we need to support each other more as a group, and maybe that's been there to some extent, but I'd like to think this year that we can build on that a bit more, and that's why we're sort of hoping to have networking forums as well as clinical supervision for psychotherapy and things like that through the college, because we need it. We do work in some incredibly tough situations, and we have to be so, you know, sometimes politically correct when we don't want to be, or we have to work with, you know, the limitations that are there, and so on. So I think the more we can sort of support each other, the better that we'll all go. And that's something I'm looking forward to this year. Okay, shall we go back to the next slide? And I will do the same. So I'm going to now, in this part, we've got about half an hour left, so I'm going to talk about a case history and also talk about the structural dissociation model, which really helped this client of mine, along with the polyvagal theory, to get out of a really tough situation that seemed to be quite hopeless in the beginning. But I just wanted to briefly talk about dissociation, because there's a lot of argument and debate, even in the psychiatric field itself, about what dissociation is. So for the purposes of our discussion today, I thought I would just try and clarify in non-jargony ways what I think of when I think of dissociation. And it has a whole, I think it's on a continuum from sort of, we all daydream when we're doing something that is not, so we think of us when we're little kids at school, waiting for the bell to go, and we'd be 1,000 miles away thinking about, the hot chocolate that we'd have when we got home, or the fight we'd have with our brother on the way home, or whatever. But we were somewhere far away. We weren't in the room. We were daydreaming. And some of the people we work with live in daydreams as a way of coping with their life. One person I'm working with, who's a cult survivor, for example, has got this amazing sort of imaginary life where she's got everything is perfect, and she's got a husband and children and all that in her imaginary world, and she spends hours there every day. But in her real life, she's a lonely single person. And it's so dissociation in that sense, in that sort of fantasy daydreaming way, can be just a survival-based strategy. But it can also be a much more on the severe end, where people can be actually in a state of hyper-aroused panic and feel beside themselves, or be out of their bodies and far away, so there can be a whole range of forms of that. And then there's the fragmentation of memory, which is obviously, if you have a car accident, it's good not to remember all the details of that. But with some of the people we work with that have more extreme presentations, one of the symptoms is that they have large chunks of time that they can't account for. Like they find clothes in their wardrobe that they don't remember having bought, or they find, one of my clients who's a vegan finds wrappers from McDonald's big, Mac burgers in her room that she doesn't remember buying, and things like that. So that can be where there's probably, when there's losing time, it's more likely to be sort of at the DID end of things. But also every single person has different parts and different parts of self. For example, if I was going to meet the Queen, I would probably have my most curtsying self there, I imagine, although I don't know, maybe the rebellious part of me would come out. I don't quite know which part of me would meet the Queen. But if I was going out into the garden to water my veggies, that would probably be a much more gentle and grounded part of me. So we all have these. Next slide, please. Most of us, however, as therapists, are taught to treat clients as a singular entity, and it's really important not to do this when we have clients who are with these extreme symptoms, because they are anything but a singular entity. All people experience a variety of self-states, and generally speaking, the more wounding or trauma experienced by the person, the more separated self-states have to become. So in people with DID, they're often people who've either, often been in a cult or a cult-like environment with very sort of systematized and multi-layered and ongoing and prolonged abuse. And often these people are, when they're young children, are given drugs as well, which, anyway, they're a much more severe presentation of dissociation. But in the structural dissociation model, which was developed, next slide please, by Janina Fisher, everyone has parts and everyone dissociates. And it's a breakthrough experience for many clients, because these people that we work with often feel puzzled or distressed by their own behaviours. For example, they push away people when they need love and support, or they harm themselves instead of reaching out for comfort and care. So the structural dissociation model actually tells a really validating and reassuring story that parts evolved at different ages and stages to cope with life experiences, just like Julie was saying before, and that creative adaptation, and that without these parts, the client may not have survived. The idea that all parts are welcome is very important, and later this year we're going to have Simon de Saulnier, I don't know if I've pronounced his last name correctly, but he teaches the inner family systems work, and he's going to give a session on this idea, the introduction to IFS work, which is that all parts are welcome, which is very important. Now, some clients have informed me over the years that they've killed off parts. However, this is not possible. Parts are always there, and they're usually listening to what's happening in the room moment to moment. So long term, again, the work is to befriend the parts and to start to hear what they're saying and to learn what they need, while the wise self guides what's happening overall. There are many benefits to working with parts for the clients. It's often very liberating for them, and it's a very hopeful framework for them. For example, it's only a part of you that's feeling distress, and there's another part of you. I think I've worded that badly. I wouldn't say to people this distress is about, can we do the next slide, please? Sorry. I wouldn't say to people, there's only a part of you. I don't know why I wrote that. I must have had a brain fade in that moment. I would say this is a really important part of you that's feeling distress. And this stress feels really real to that part. And even though nothing bad is happening to you now, I know this part feels like it really is happening right now. Do you get a sense of that, where you're trying to validate whatever the parts are experiencing and helping the client to connect with those parts in a non-stigmatizing and non-fearful way, a non-rejecting way? So we lead the way as therapists in this structural dissociation model, and parts will not like being ignored or dismissed once they know there's a chance to be heard. In fact, I had a client tell me last week, that her young parts were very unhappy because we were still working via Zoom because of COVID, and they were very unhappy. They were protesting. So it can be wonderful when that communication starts to build in the work. Now, there's lots of resources, and we talked about that a bit in the break, that the flip chart of Janina Fisher and stuff, but there are many, many resources online. Even if you just Google images for structural dissociation on your computer, you'll find lots of information there. But what I like to do with clients, and the next slide please, Ellen, is simply just draw a diagram to introduce the ideas. So we were talking earlier about how trauma sometimes creates a very over-responsible, over-functioning everyday life self. That's the EDL self on this slide, that is caretaking and responsible and whatever. And that part can go through life not even really aware that there's any trauma until something happens that triggers the traumatized self. And then any of 5 functions can emerge: fight, flight, freeze, collapse, or submit, and attach. Now, the fight part has 2 modes. We can either fight ourselves or we can fight others. And the attach part has 2 modes. We can say yes to love and belonging, or we can say no if love has been really scary in the past. None of these parts are good or bad. They're all precious and important, and understanding and befriending them is the key to healing from really complex trauma. Anyway, when I introduced this idea to Penny, who's our case study tonight, she was amazed by this model, and it was a real turning point in our work together. She found it very comforting and validating. Understanding this model does tend to alleviate a lot of embarrassment or shame that the person is feeling about their condition. Symptoms can be reframed as an adaptation for survival. Again, that's that Gestalt thing that we were talking about earlier. For example, anxiety is associated with flight. It's a desire to avoid undesirable feelings or situations. Suicidality is viewed as a way to avoid emotional or physical pain. That could be fight or flight, because we're either fighting ourselves or we're wanting to run away from the pain of living. Self-harm can be flight, as in an attempt to re-regulate an intense emotional state, or it can be fight, to punish or misdirect anger that belongs externally. And one of the things that really helped Penny was learning to actually externalize her anger, because prior to our work together, she'd been quite an internalizer. And once she learned how to be a bit more angry in the outside world and put the anger to where it belonged, she stopped. Her self-harm really started to decrease. And now it's stopped altogether. The idea is to collaborate, though. There's no sort of map that works for everybody all the time. The idea is to collaborate with the client to help map out how their system works. And, you know, some people, I would say that in all the people I work with, probably the attached part has the most sway over the whole system. Because when you think about it, if we're a little baby, 0 to 6 months, and we don't have a person or, you know, someone to attach to, we die. So that part tends to be very powerful amongst in this structure, and it can influence other parts to become activated. So example, the person that was, I'm sorry, I've forgotten your name, the lady that was talking earlier about that experience at work where she was really being dismissed by her colleagues, that may have activated for her a fight or flight part, you know, or even a freeze part. I'm not sure exactly what was happening there for her, but you know, we can see how that sense of being rejected from our tribe and not belonging can really activate other parts. And this is very reassuring for clients when they understand that their parts don't have to shout to be heard. We can do compassionate noticing, and they're helped to sort of deepen their understanding and to listen. And so over time they develop this, they befriend their parts and they learn to collaborate and cooperate inside. And that really alleviates or heals symptoms. And so we start as psychotherapists by unconditionally conveying our acceptance and working toward adding to their early survival-based functions. So then the client has more hope and options for the future. Next slide, please. So here's our case study. Penny was a 31-year-old woman with significant pain and full immobility caused by chronic regional pain syndrome, needing 24-hour hospital care. Previously, she was an elite athlete. She was a swimmer and at the top of her professional career. Prior to physical collapse, vigorous exercise was her main coping strategy for stress and anxiety. As I said, she was an internalizer. She had a complex trauma history of which she was completely unaware, holding an idealized version of her history. In fact, when I first met her, she told me she had a really super happy childhood. Her parents were wonderful. There was nothing to see and please move along. She was quite dismissive of me when I first met her. Next slide, please. Penny had migrated from South Africa as a young woman. She suffered an injury several years earlier while rowing. Post-op, the pain got worse and started to spread throughout her body. This is the progression of chronic regional pain syndrome. She was also working 17 hours a day, 7 days a week in her job as an accountant. Her gut had become atonic due to stress and exhaustion, but nonetheless, she kept going to work with a nasogastric tube in place. So that tells us, doesn't it, that she didn't have that neuroception that Stephen Porges talked about back then. She just had no awareness of what she was doing to her body. Penny had never had a serious relationship and was involved in helping children through her church. At the time I asked to see her, she was catheterized and bedbound. Her whole body was excruciating and in pain. The only part of her body she could use were 2 fingers on one hand, literally. She was completely physically collapsed. Now, Penny was angry. The head of the pain team had told her that there was nothing more they could do for her and she would have to live in excruciating pain for the rest of her life. The prognosis triggered frequent self-harm and suicide attempts, and Penny stopped eating. When the pain or emotions became too intense, she would experience dorsal vagal dissociation, becoming non-responsive to pain or verbal stimuli, sometimes for hours at a time. She was unconscious. The ward did not know what to do as the risk was very high when she was awake. Some staff were avoiding her, traumatised by her behaviours. They were preparing to send her to a nursing home with a stomach peg, I believe, when I first met her. The consultation liaison psychiatrist asked me to see her but warned her prognosis was very poor. Next slide, please. Can just skip through these because we're almost at time. So I didn't start asking about her trauma history straight away because in trauma work these days we want to avoid the inadvertent re-traumatization, because talking about trauma often evokes flashbacks or re-experiencing phenomena. So we don't want to start the detailed trauma history straight away. But I could ask about her symptoms and resources and systemic factors, and found that all her friends and boyfriend had deserted her and her family was overseas. So I found out that her tangible resources were quite low. She didn't believe in psychotherapy and was dismissive at first. Next slide, please. Both. Yeah, next. Penny's nervous system was fighting itself. She alternated between those extremes. And when she was in sympathetic activation, of course, our muscles tighten. So her pain became profoundly worse every time she was activated. The dorsal vagal dissociation, interestingly, was a release for that pain. So she would go into these profound states of total relaxation and collapse, in dorsal vagal collapse, and that would help to moderate her pain. So she alternated between intense pain and unconsciousness, which alleviated the pain. So at first it seemed the window of tolerance would be difficult to achieve. I spent many sessions resourcing with Penny and building the therapeutic relationship. At first she dissociated profoundly at every one of our sessions. I noted after a while, however, that these dissociative episodes tended to be toward the end of the session when it was time for me to leave. This was a light bulb moment for me. It gave me an indication that our therapeutic relationship was progressing enough to start some psychoeducation and other work. Because it meant that there was something about the work with me that she didn't want. She was painful for her to lose. Next slide, please. Both. Yeah. It's important to use psychoed as simply as possible at first for clients at the extreme of dysregulation. Due to alterations in hearing caused by stress, prosody of the therapist needs to be slow and calm. In Penny's case, she settled enough to learn more about the polyvagal theory and structural dissociation as the weeks and months progressed. She found the structural dissociation model particularly validating, as it reassured her that she was not mad or bad, something she had believed before this. Next, please. Swinging from hyper to hypoarousal is common for trauma survivors. And so what I did was a lot of validating and normalizing and offering hope. And this is something that every nurse can do. Next slide, please. There were many issues. At first, Penny was drugged and dissociated. She couldn't use any large muscles and she was on huge doses of psychotropic meds. The conditions were not easy or smooth, and the hospital was putting continuous pressure on her to discharge, despite her complete physical collapse and immobility and poor pain control. And I want to actually acknowledge Julie in this, because if it wasn't for Julie, I don't know what would have happened to this patient. She was involved and she really made a difference in allowing time for this person to get better or make some progress. I went into the hospital weekly for psychotherapy and offered several times to support and educate the doctors and nurses. But the charge nurses and the doctors told me they didn't need my help. However, Penny's risk was so high that they ended up keeping her as an inpatient for a couple of years, albeit moving her to different wards as her behaviours were so stressful for staff. The things that happened to her in hospital were not consistent with trauma-informed practice, unfortunately, in many cases, and even management of the chronic regional pain syndrome. Lucky she was angry, so this motivated her to get better despite the system that she was in. And the first thing we did was I encouraged her to use large muscles to push, and she found the push empowering, and it also gave her some relief from the stress she was in, so she agreed to do this regularly during the day. Next slide, please. Yeah, all of those. So at first she pushed too enthusiastically, and this made the pain worse, but she learned to titrate this within pain tolerance gradually. She had one good night's sleep and felt much better. This surprised her and gave an inkling of hope. We added breath and spine lengthening and other movements as her body gradually came online. She started initiating gentle yoga at night when she couldn't sleep, and weighted blankets and toys helped to soothe her sympathetic nervous system. There was lots of mindfulness and art therapy. And look, the hospital staff, some of them were really wonderful to her, though she did resist help at first. She resisted a lot of help at first. Next slide, please. In this phase, we work toward cultivating the dual awareness. Now, this is going back to the structural dissociation model. So there's the everyday life self, which can become the wise self or the protective self, which is looking after the activated parts. This is what I mean by dual awareness. Penny's episodes of self-harm and suicidality gradually decreased in frequency as she discovered other ways to soothe and settle herself. However, there was a huge setback where she was sexually assaulted. This was reported immediately, but somehow she was victim blamed despite being almost completely unable to move her body. And flashbacks from the experience and her childhood sexual abuse came flooding back, and she appeared to regress as the physical pain flared up and dissociation deepened. The hospital tried to discharge her to a nursing home again or into my care, and I was quite incredulous. We eventually got her into a supported residential space where for the first time in a couple of years she started to feel safe. And again, I really want to thank all the people. There were some wonderful people that really helped with getting her there. Next, she regained some mobility and appetite and started aiming for independent living after 2.5 years of being a high-risk inpatient. Later, she moved to her own unit with some practical help from NDIS and a special wheelchair. Self-harm and suicidality disappeared completely as her autonomy and sense of hope and purpose returned. She is now fully recovered and independent and has a dog which has she says it has noticeably reduced her dissociation. This is she's training it to be a service dog. Penny has a very healthy social life now and is doing volunteer work. She's out of the wheelchair, walking, running, swimming and bike riding. And 7 years later, she has given a number of public presentations about her recovery process and is studying for a new career. And of course, she's given permission for me to talk about her. And that is my story of working with extremes. So we have questions. We've got a couple of minutes for questions and feedback, and just generally any comments that people want to make.
Claire, I'm interested in the resourcing phase and what you mean by resourcing.
So resourcing is we can do, let me see, I'm going to see if I can find it here. I've got some extra slides here that you can't see. But look, basically resourcing is all sorts of, you can ask a person, for example, to tell you about a time in their life when they felt they'd completed something, or they were proud of something, or enjoyed a meal. Or you can ask them what they like to cook, what they enjoy doing. You can ask them what their favorite movie is. Anything that evokes a positive interior experience is resourcing. If they love animals, you can talk to them about animals. If they, anything can be used as a resource. And in her case, I was trying to get her to learn about her body as a resource too. So that thing of pushing with the leg, that was a form of resourcing as well, because it gave her relief from the intensity of her inner experience. So there's, I could do a whole 2 hours just on resourcing. There's so many ways to do it, but there's many things we can do. And even things like giving people choices in the conversation, like, do you want me to sit here, or do you want me to sit there? That's resourcing for them, because you're giving them some power and control over what's happening in the room where you're working with them. There's so many ways we can resource people.
Thank you.
Claire, I have a question. How would you how would you classify dissociation with BPD and schizophrenia? Like schizophrenic patients, they hear voices and all, and then they just dissociate sometimes, and they're not engaging. So how would you start psychotherapy with them? And also for borderline.
Right. Well, dissociation, in essence, is a response to extreme stress or fear. It's get me out of here. So depending on what their auditory hallucinations are, and depending on what their other survival coping strategies are, they can have many different types of dissociative responses to whatever is going on. I don't really like the label BPD, as you may have gathered from my presentation tonight, because the DSM taxonomy is not evidence-based or valid or reliable. So I would prefer to use the term someone with a complex past or complex experiences. I don't know, people would probably argue with me on this, what people think, but I think it's important that we hold hold these labels lightly, and try and understand the person that we're with, rather than trying to put people into boxes with labels on them. I think it's more important to sort of understand the human that we're in the room with and what they're dissociative, and ask them.
So when asked one of the patients, she has just been in her room. There was an incident of physical assault. Like she said, the voices are telling me to choke people. And then when she was taken from LDU to HDU, the patient was just in the room. She was just staying in the room. So that's what I'm talking about, dissociation, if you understand what I mean.
Well, hallucinations can be very terrifying and frightening for people, and a fear response can cause dissociation, and hallucination is not the same as dissociation. It's a different kind of, one is a cause, if you like, or a trigger, and one's a response to the trigger. Hallucination is the trigger, and the dissociation is the response to the trigger. Does that make sense? And then your job then, in that case, if the patient is frightened, is to ask yourself, how do I help that person feel safer? What can I do that, brings more safety into the room right now? How can I soothe and settle this person's nervous system using the polyvagal theory that I've learnt about? Can I use my tone of voice? If I use a soft, gentle prosody rather than an anxious prosody, is that going to help them to settle more? Let's think about the person that you're with, if you can, will help your work.
Thank you.